you have to have a doctor send you there, or can you do it on your own?
No, family patients can request on their own.
That's what I understood at the beginning.
What we do is we have to have a doctor to admit, and our doctor too, and we have to have a doctor, when we admit patients, sort of participate in the quote, sending doctor should participate by providing documentation that helps us establish a chart so that we can pick up care without reinventing the wheel. And all of them do. If they come to us, all the doctors always do. So they're very good at that. Even doctors who come from home. I get patients from home, mostly for wounds and things. And those, I call the family doctors, and they provide all the information they can. And sometimes the home health agencies and the oxygen equipment agencies and all that. This way, just, yes, ma'am.
I was just gonna ask you, are you educating patients so they can go home,
Oh, absolutely.
whether or
Yes,
not
ma'am.
they're on a vent or not?
Yes, ma'am. A big part of what we do is patient education. We even have patients that go home on ventilators. If we can't get them off a vent, there are options. One of the options is do you have the family support? And if so, we set them up with all the agencies, the funding, and our case managers are very aware of that, and the in-house practice, and so they're comfortable to go home. That's absolutely good question. Yes, ma'am.
So could you give me the name of pulmonary doctor?
I would prefer really
No, I
not
mean,
to.
just to, just, I mean, I'm not
Yeah,
saying
yeah.
anything bad against
Yeah,
any
yeah.
doctor. Just,
It's one of those things that it's a sort of a professional sort of courtesy that.
well, the only reason I'm saying so is because, I'm here with my husband, like I said, okay? And his sister, okay, our second opinion was the doctor that I mentioned, okay? And, I don't know if I should say this, he has chosen not to have the lung transplant. And we went to Duke University. But I just think, maybe we should look at another lung doctor. What's wrong with that? I don't see anything wrong.
Give me a chance to think about that for a little bit, because, I mean, it's one of those things that would be very politically incorrect.
Okay, we haven't even seen him that long at all.
Let me think about that. Let me put it in my old noggin. I'm a little old. We'll let it go around a little while. See what pops out. If anything pops out that I need, please hand it back to
I have
me.
a suggestion.
Yes, ma'am.
Pulmonary Associates of Richmond has got 20-something board-certified lung doctors.
Yeah.
Yeah.
That's what she's talking with them.
Yeah.
That's where she
Yeah.
is. That's where she is.
Yeah.
Okay, sorry. That's where she is. But different doctors have different philosophies. And that's where she is also. And he's got to be careful how he treats him on that.
I'm with Pulmonary Associates, and I recently changed doctors. I've been going to Dr. Wilkinson since 1991. He's in the West End. Every time I get sick, I come to Chippenham, and I've done that for a number of years. I see the doctors at the Boulders. So I recently changed to the one at the Boulders. You can change within that firm.
Sure.
Yeah, so,
And,
yeah.
so,
And there's tons of them in there.
so he's in there?
Yeah, and that's when I went to Jamie Hay, and he is certified.
You got,
Yeah.
But Washington, one I didn't like it, it's just this one is on this side of the bridge.
my wife like that. Okay, where was it? One thing I want to make clarify too, that we are only an inpatient hospital, so our pulmonologist does not see people on outpatient. So once people come to us, we always do a discharge summary and get them back to, wherever the patient family wants to go and help get that information back to them. How are we doing for time?
You've got 40 more minutes.
Oh, okay, I'll start talking slowly then. Do we cover everything? Yeah, I think we did. Okay, this is a typical patient. Okay, the respiratory failure on a ventilator. This is just sort of some egghead stuff, but this is how you define it. If you're on a ventilator greater than 6 hours a day, that's considered ventilator dependent. That doesn't mean you're ventilator dependent for the rest of your life. That means that you're ventilator dependent for the moment. every day you must have a ventilator for at least 6 hours. It's not uncommon for us to see people who are on a ventilator at night for 8 hours, and often in the day, with different illnesses that cause that sort of thing. A lot of the patients that we send home, I have a guy who works, and he's on a ventilator at night. He's got his own business from home. Amazing man. Every now and then he gets a pulmonary infection, and he needs to come into the hospital. He gets back on the vent for 24 hours a day, comes over to us. We've been able to get him off the vent, treat his infection, wean him back to his baseline, which is home on vent. So there's a lot more technology these days than people would expect. There was a time when people thought if you were on a ventilator, that was it. Believe me, that's not the case. 85%, we our normal, 85% is the lowest we've been in 6 months, but our normal is about 55, 56, 57%. I really can't tell you why we're all of a sudden at 85, but that's still above the national average. The national average benchmark is 42%. So, for 6 months we've been doubling that. Okay, so weaning potential, so FiO2 is less than 50. If you're on, these are just ventilator settings. If you're on more than 50% of oxygen, this is a blood oxygen, then that's still at a critical care. That's an ICU level. That's the reason to stay because you're not stable enough to come to us. So a lot of this, we don't, deep sedation of patients are on, sometimes you see when people are put on a ventilator, they need to be put on propofol or fentanyl drips. And those are drips that pretty well knock you out because it's so agitating and upsetting or anxiety causing with the ventilator that they really knock people out, and that's to help them not panic so much. And then they try to wean them from the sedation to a point where they can be aware so we can start to do weaning. So we don't take patients on deep sedation. Some LTACs in other states do, but we don't. We think that's still hospital level, general hospital. So the patients require 24-hour-a-day respiratory services. I had a doctor recently tell me, we don't have respiratory therapists at night. The condition for participation in Medicare and most all the commercial insurances is 24-hour-a-day respiratory therapy. We have, years ago, we did have MCV pulmonary covering our own pulmonary group before we hired our own. They said our respiratory therapy department, MCV pulmonary, especially, it was Dr. Fowler. You might know Dr. Fowler at MCV? Dr. Fowler said that this is the best, ours was the best respiratory group in town. This goes in, we're veering into the bragging portion of the presentation. So I want to bring your attention to this. I just handed this out with the group. This says 2012, I believe. I think, let's see. This is an award that we've won every year since 2009. So 9, 10, 11, 12, and we just heard last month we won it again in 2013. And it's a little award, it's for respiratory excellence. So our respiratory therapists help us get that award. So really, since we've been in existence, except for the first year. So every year we've applied for it. So some other things, I really sort of put that in. We talked a little bit about antibiotics. Pulmonary problems aren't always the breathing, the ventilation, the oxygen. If you get infections, it's very important to take care of those infections correctly the first time because, as I knew in my mother's case, who had lung cancer, each infection or subsequent infection, you lose breath function. You might get over the infection, but you can lose lung capacity. So having proper, push the wrong button, proper infectious disease coverage for antibiotics, and that could be pneumonias, bacteremias, all the emas and itises. Anything you see that, that's what we look at. And we're looking at patients that have need for multiple antibiotics long term, meaning over 2 weeks. Non-vent, these are the actively treated primary problems. This one is the O2 greater than 40%, that's a cold collar usually, or COPD with 2 or more inpatient admits in the last 6 months. So if you're having serial admits and you're not able to break out of that cycle, that's a Medicare reason to consider a level of care like ours, so we can take a longer, a deeper view of the problem and the treatment and assurance that they're getting out of that. No guarantees on anything, but this is the way we're set up. These are the things we look for to try to help people. And we've been very successful, but it's like anything else in this world, there's really no guarantee, right? I have a lot of confidence. Cardiac patients with respiratory interventions requiring Q4 hours. So that's like the patients that are on jet nebulizer treatments in 4 hours or more a day. That's a higher level of care. That's not something that can be done consistently in a nursing facility, and you can't be done by home health. So, even people who are desatted, these types of things, are reasons for this as well. So, all right, medically complex patients, the primary treatment of chronic renal. So, these are patients that have additional problems other than respiratory, or that can be standalone. So this one sort of is just in there. I mean, malignant or end-stage diseases, COPD, CHF, these are considered not malignant, but they're considered end-stage diseases in that there's no cure for them. You don't have to be at the end of life. It's a tough definition because it sounds like end is not a good word. It means it's a chronic, serious, progressive, often degenerative disease. So the length of time of progression and degeneration in the disease is dependent on a lot of factors. Some of those are lifestyle, understanding your illness, what you can do about it, and the other treatments on the other side. So there are a variety of other groups besides myself that do education before you need a ventilator. I know, for instance, the people at Health South Rehab have a pulmonary rehab program, and there's a whole series of education sessions for their inpatient patients on how to cope with, how to take your nebulizers correctly, how to eat correctly, what are triggers for exacerbations of the problem. So there are lots of other support in this area. Cardiovascular, peripheral vascular. A lot of people obviously with pulmonary disease also have cardiac problems, might also have some vascular problems, some DVD, things like that. Those complications can communicate with the pulmonary problem to make it worse faster. So, the whole person approach is obviously what we like to do. There's a question there. One other handout I wanted to just bring attention. Then I'd like to talk or open up for some questions. These are some patients that we had. Every last one of these patients have signed a waiver, so we can put their name if we want.